Dr. Juan Sanchez-Ramos.
Thank you. I just saw the questions right now. So these are a list of questions. It would be nice to get them yesterday, then I could prepare, but they're pretty straightforward. So, well, I'll make them up if I don't. So I'm not gonna take them in the order that they're here. But are there any new drugs coming for Parkinson's disease? Well, that one I'd heard about one for some time called sulfonamide. It's been just finished phase 3 studies. That means it's still under clinical research, but the outcomes look favorable, and probably they just need final approval from the FDA. And I'll tell you why that's an interesting drug. Sulfonamide, S-A-F-I-N-A-M-I-D-E, is a drug that would be geared to treating motor fluctuations that people develop after they've been on levodopa for some time. Many of you understand what I mean by that. Initially, the levodopa or dopamine replacement alleviates slowness and rigidity. Then you get a gradual loss of the benefit. It kind of wears off sooner and sooner. But that's usually adjustable. I mean, one can treat that by adjusting the schedule of medications. But what happens later is the development of excessive involuntary movements called levodopa-induced dyskinesias. And these can be very incapacitating for many people. So we've always struggled with this. When they're really difficult to control by adjusting schedules of medication, we tend to refer the patients to for deep brain stimulation, which has some very good control of the severe ups and downs that people have. And so typically I don't like to do that right away. I like to adjust medicines as long as possible. For example, using the new Pro patch to result in more constant levels of dopamine stimulation. But this new drug is one that is new in several ways. First, it would be mostly geared towards treating people that have these dyskinesias and ups and downs. It's also, even before then, it's useful to potentiate or to increase the effects of levodopa. But what's also new about it is how it works. Most drugs have one mechanism of action. It'll inhibit an enzyme, for example, like Azilect. All that Azilect does is inhibit an enzyme that breaks down dopamine. That's an example. Or a dopamine agonist just acts on dopamine receptors. I mean, that's what we hope. If you give too high a dose, it acts on other receptors and you get all kinds of side effects. But sulfonamide will increase the effects of dopamine by inhibiting MAO, like Azilect and selegiline, by inhibiting the termination of dopamine action, kind of like some psychomotor stimulants do, and by inhibiting release of glutamate. And that latter effect may be neuroprotective and is somehow involved in stabilizing the response. So it's a really interesting drug because it acts on two different neurotransmitter systems, the glutamate system and the dopamine system. So I'm looking forward to, I've heard people who have been in the studies say they're very pleased with the data, and hopefully in this coming, by the end of the year or early 2015, we'll have it available for prescription for the general population of Parkinson's patients. So that's the most important. There's several other drugs that are aimed to treat dyskinesias, but they're further away. And if you go on the cruise, you'll learn a lot about a lot of drugs in the pipeline, because Dr. Clarence Smith and Dr. Chase are really involved in this whole drug development story. So we'll go to more common, simple questions. They're not really, nothing is really simple. But how important is it to take your medication on time? And how should I do? What should I do if I miss a dose? Well, it depends on the medication. You know how many medicines that you may be taking? If you're taking levodopa, it's very important you take it on time, because levodopa has a limited duration of action. Especially if you've been taking it for 3 or 4 years, it's going to wear off by 3 hours. So if you miss a dose and you end up taking it 6 hours, you're going to have a period of time where you're not going to be on So it's important not to miss doses of levodopa, nor to miss doses of dopamine agonists, that is Requip or Mirapex or Nupro. Nupro is fairly easy, it's just once a day. And if you forget to put it on at 9 in the morning, well, put it on at 10 or 11. It's not a big deal. If you miss the Sinemet, for example, and you normally take it every 3 hours, and by the 5th hour, you've gone 2 hours with it off and you can hardly move, I would take it right then and then go back to every 3 hours. Just, catch up that way. Don't take extra tablets. Just take that if you just remember to take it, but then the next dose after that should be every 3 or 4 hours, depending on what your schedule is. So in the case of other drugs, like anticholinergic drugs like Artane and Cogentin, which I don't prescribe that much in people over 60 because it tends to, number one, cause urinary retention, difficulty in emptying the bladder, cause short-term memory problems, and can cause confusion. So I tend not to use it. But that's one also that you should take exactly on time. If you miss a dose, that's not so bad. I wouldn't, worry about it. I'd get back into the regular schedule. That's for the anticholinergic drugs. If it's a drug like Azilect, you miss a dose, it's only once a day, well, start again the next day. Don't just take it later in the afternoon and then take it the next morning. That one is okay to resume, because the benefit of the Azilect lasts for days and weeks. So if you miss a dose, you won't notice much difference. So if you miss a dose, today you forgot to take your morning dose of Azilect, well, don't take it now. Take it tomorrow morning. I think that covers most of the drugs. For the antidepressants, some of the antidepressants you take in the day, I'm talking about the Prozac, Zoloft, the SSRIs. It's important that you don't miss those, but if you forget to take it in the morning, it's okay to take it in the afternoon. Some of these SSRIs that I prescribe for daytime use, you shouldn't take before you go to bed. If you forgot the morning dose and you're almost ready to go to bed, oh, I forgot that dose, I better take it now. No, don't do that. Take it the next day. The nighttime medicines, if you forget to take them at nighttime, there are a number of antidepressants I prescribe at bedtime, mirtazapine, doxepin. If you forget them that night, don't take them until the next night. Don't take it at 3 in the morning because, oh yeah, I forgot. That's why I've been tossing and turning. I'm going to take it at 3. Well, then you're going to sleep till about noon or 2 in the next day. So better to get some hot milk and honey, drink it and go back to bed. So such a simple question, right? Was my answer simple? No. But I have to tell the truth. It's not so simple. You have to find out what is your normal regimen of medicine, what is the class of medicine, etc. The most important medicines not to miss are your dopamine replacement medicines. And those are levodopa carbidopa, known as Sinemet, or CR Sinemet, or extended release Sinemet. The dopamine agonists, those are synthetic dopamine drugs, Requip or ropinirole, Mirapex or pramipexole, and Nupro or rotigotine. Those things you shouldn't miss. How can you tell, or is it possible to tell, if the Parkinson patient is over-medicated? Yeah, well, first of all, if someone has peak dose dyskinesias, that's very easy. But you have to understand what I mean by that. I explained it earlier, but it means that when you take Sinemet, an hour after, you get an incredible amount of involuntary movements. If it occurs an hour after taking it, that dose is too big. That dose is it's over-medication for that dose. So you have to taper it down. If a person is hallucinating and confused when he takes the medicine, it means several of things. It means, number one, they may be taking too much anti-Parkinson medicine, and number two, they probably have an underlying dementia and a sleep disorder. So if someone is, every time they take their medicine, or when I see them, they're really confused, disoriented, sometimes seeing things that aren't there, the first thing I'm going to do is cut back on the medicine, because oftentimes over-medication with anti-Parkinson drugs or anticholinergic drugs can cause confusion, disorientation. The other thing I do, if someone has been fine, there's just mild dementia, and then from one day to the next 3 or 4 days, the family calls you, the caregiver calls you, the husband or wife, and he said, I don't know, he's just not himself, or she's very confused, they're disoriented, they walk into the closet instead of the bathroom. Typically, if it's happened very quickly, that's a red flag that they have not over-medication, because they haven't changed the medicine, right? They have a urinary tract infection, or pneumonia, or some other physiological event going on, and that requires trip to your primary care doctor, urine sample, listen to the chest, etc., to make sure there's no pneumonia or bladder infection. So a sudden, what looks like an overdose, and without there being an overdose, make sure the patient didn't accidentally take more medicines, because that can, of course, cause that same confusion and disorientation. I've seen people come in with 18 tablets of Sinemet a day. And if I notice, I didn't say, if I count that they take more than 12 Sinemets, that's over-medicated? Not necessarily true. Every patient can tolerate different levels of levodopa. So I don't say there's an absolute level where I would say, just by looking at how many tablets you take, that you're over-medicated. I look at the patient, how well the patient's doing. The reason some people can take 18 tablets a day, they may be 6'5", 280 pounds, they need more medicine, or they eat tons of protein. They have a glass of milk with every meal. They have a protein nutrition. Those things interfere with levodopa getting into the brain, therefore they take a lot of levodopa. So you can't just gauge by the total number of tablets they take, use that as an index of over-medication. That's the first kind of response. When I see the list of medicines, if there are more medicines than I can count on my hands, I tend to think they're over-medicated. But I have to be very careful about that, because they may have a lot of other conditions, and they have a lot of doctors. And for each condition, they're on 2 or 3 medicines. And for Parkinson's, these are on 4 medicines. So we call that polypharmacy. I try to simplify as best as possible. So too many medicines that I can't count on my fingers is sometimes too much medication. What's available to ease both Parkinson plus lower leg neuropathy without oral medications? So that's Parkinson plus. I don't know if they mean Parkinson's disease and lower leg neuropathy, or Parkinson plus meaning atypical Parkinsonism. Who wrote that question? Do you mean Parkinson plus? You mean atypical Parkinsonism? Oh, Parkinson's and. Okay. Because Parkinson plus may have neuropathy. There are some forms of atypical Parkinsonism where there's a neuropathy as well.
Can it be aggravated by Parkinson's?
Well, what's aggravated is your balance in walking. The symptoms will be worse if you have a combination of neuropathy, which can result in abnormal position sense, so you're going to lose your balance just with peripheral neuropathy alone. Ask any diabetic. They're going to have problems with balance because they feel numbness on the bottoms of the feet. They've lost an important way of gauging where their body is in space, and they're going to fall. If you have Parkinson's disease, stage 3 or more, you're going to lose your balance because of the central processes that regulate your position of your body in space. So if you have neuropathy, Parkinson's disease, you're blind and deaf, you better have someone escort you, because all of the things that protect your body from falling are gone. All systems are kaput. So deafness, your inner ear, blindness, or loss of orientation in space, and proprioception that's the disaster for falling. And that's why people in their 90s always fall, because all those systems gradually decline. Your peripheral neuropathy, your position sense, which allows you to stand on one foot and close your eyes, and you know exactly where you are because you have your inner ear and position sense. You can't do that when you're 95 unless you're a yoga master and you've been doing yoga all your life, because you can exercise that. You can prevent it from going away. But if you're on your butt all the time and don't exercise and try to work on your balance, you're going to fall sooner than you should. So what do you do about the neuropathy? Without oral medications? You mean injections instead? No medicines, without any medicines.
Specific physical therapy regimen that would...
Yeah, well, yes, physical therapy. Well, that's why I refer so many of my patients have gait and balance problems to physical therapy. There's a lot that can be done by repetition and exercise and relearning. Yeah, there's a lot. In fact, ideally is use something to decrease the discomfort of the neuropathy, because a lot of neuropathies are somewhat painful or irritating. So use gabapentin or Lyrica plus the physical therapy. That works better than just physical therapy or just medication alone.
This is my first trip here, so I didn't know if you had the right question.
Well, there's about 12 questions. You may ask it, and I'll see if it's already here.
In dealing with someone who has the early symptoms of Parkinson, and she also has hypertension, the high blood pressure, and hypotension.
Both high and low.
High and low, and she's on Cinnamon. Now, as far as the hours in between, is there like a certain amount of time that I should give her the medication? So that, because Parkinson, Cinnamon can lower the blood pressure, and then the others naturally.
Well, people with Parkinson's disease will occasionally have a big drop in blood pressure when they stand up. That's called orthostatic hypotension.
Yeah.
But when it's really severe, from just going from lying to sitting and your pressure drops, that's a Shy-Drager syndrome. It's an atypical Parkinsonism. And the first priority is to maintain the blood pressure before you start adding Sinemet, because Sinemet will aggravate the low blood pressure. So you need to see an expert. I can't give you a simple way to do this. But it's a number of steps in managing people with Shy-Drager. If she doesn't have so-called Shy-Drager, it sounds like she does because she has really high and really low. In Shy-Drager, if you lie down, your pressure is too high. If you stand up, it's too low. So what you do is you never let people lie flat. They have the most they ever lie down is 45 degrees. You need a hospital bed or a wedge, a foam wedge pillow. So they never lie flat, because they lie flat, the medicines I give to increase the blood pressure will result in excessively high blood pressure in the brain when they lie flat. So you never let them lie flat for sleep. Secondly, you give them things that prevent pooling of blood in the lower extremities. So TED hose up to the thigh, things that people in Sarasota love to wear, right? You got to put them on in the morning. You put talcum powder in them and you roll them up and make pretend it's glamorous, because it's kind of uncomfortable. But if you are able to stand up without fainting, you'll love those stockings.
Mine wears them. Yeah.
Yeah, and the third step, besides the sleeping position, the TED hose, I'm going in, and what things that you can do simply is to add salt to the diet, provided she doesn't have congestive heart failure or any cardiac issues. The salt will increase the blood volume, will maintain a baseline higher blood pressure, so that when she stands up, there's not as big a drop. And finally, if that fails, there are medicines to increase the salt in retention by the kidneys. And also there are medicines that constrict the arteries a bit. But those have a lot more problems. So it's very complicated. I wouldn't eliminate the Sinemet. You may end up giving her a little less Sinemet more frequently if that is responsible for the big changes. But typically, what you do is make sure the pressure doesn't fluctuate that much, and then you can adjust the Sinemet to improve the slowness and rigidity. So, by the way, you need a good doctor who specializes in atypical Parkinsonism. I don't know how many general neurologists in Sarasota have the patience to manage it. Why do more men than women get Parkinson's disease? First of all, it is a fact that more men than women get Parkinson's disease. I wrote for the quarterly PD update, which all of you should have received, a pretty extensive review on men and women, how they differ in their Parkinson's disease, and whether or not estrogen has an important role in this, and whether or not women who are postmenopausal should take estrogen to prevent the likelihood of developing Parkinson's disease, and whether or not it's helpful in managing Parkinson's disease. That's all reviewed, and it took me a lot of writing. I can't answer it. But the fact is, more men than women get Parkinson's disease, and we think it has to do with the female hormones. And, oh, this is good.
Dr. Early, while you're on the subject of the draft, I couldn't get the hose on, so I found these ferro wrap. And I found I could get them on by myself. They have a liner.
Well, a lot of people wear those just because of varicose veins and ankle swelling. And if that's all you're wearing it for, perfect. But if you're wearing it to prevent drops in blood pressure, inadequate. It has to be really thigh high. It's, I don't know if many of you have seen paramedic, ambulances. They always carry a whole body suit that they inflate. Someone is in hemorrhagic shock because they've lost all the blood, means their blood pressure is real low, so they're not getting blood to the brain. They're probably unconscious. Their heart's not even getting blood. Their kidneys are not getting blood. What they do is compress the whole body so there's no blood pooling in the extremities and keep all the blood in the chest and head. So those are these like inflatable body pressure suits that are used in emergency situations. In the case of low blood pressure on standing, you don't need to put the whole body in, just from the thighs down. This is another one. Do the on-off periods that people experience with Parkinson's disease run in cycles? Of course. They run in cycles, and the on and off, a lot of people are confused what I mean by on and off, sudden off, and freezing. They have definitions. On and off refers to a gradual wearing off of the benefits of levodopa. And I ask people, how do you know whether you're on and whether you're off? The way I define it is that when you're on, your motor function is pretty good. You can move, you can get up out of a chair, you can use your hands. You may have less tremor. When you're off, harder to move, you're very slow, you may have a lot of tremor. And the transition from on to off doesn't happen like that in the on-off definition. It's a gradual wearing off, and that has to do with the fact that levodopa circulating in the body is eliminated very quickly. So by 3 hours after taking it, there's hardly any levodopa in the blood. And why people don't wear off in the beginning is that they have enough storage capacity in their brain, they have enough dopamine neurons left, that levodopa that got into the brain and was made into dopamine is stored and released for up to 6-8 hours. So you can get by with only 3 tablets a day without any off. But with time, the capacity to store dopamine is diminished because there's less and less dopamine neurons over the years. So that your clinical response of being on depends on the blood levels of levodopa. That's why that's called wearing off is a pharmacokinetic issue. Kinetics of drugs, the movement of drugs. Drugs don't just go in and magically turn on a switch. There's a whole process. The drug is taken into your mouth, it's dissolved, it's all time dependent. It goes from stomach, it's starting to be absorbed into the blood, from the small intestine absorbed into the blood. It goes into the liver. A lot of that levodopa is broken down unless you take carbidopa, and that's why you give it. And then that circulating levodopa is gradually transported from blood to brain in an energy-dependent system. And what I mean that it's a pump that takes levodopa from blood to brain. And if you have a lot of amino acids and proteins, you're going to have even a more delayed effect of levodopa. And you may not get enough of it in the brain.
Sounds like it would be helpful for the physician if the patient and or caregiver kept a journal.
Absolutely. I always tell them, anyone who comes in and tells me I'm wearing off, I'd like them. And when do you have your dyskinesia? Does it occur an hour after, or does it occur, because there's an end of dose dyskinesia. Yeah, there's got to be. In fact, maybe Parkinson Place can come up with a standard diary we can give everyone. Yeah. But in any case, those diaries exist often in clinical studies. We'll give diaries, and every hour you have to fill out whether you're on, if you feel you're on without dyskinesias, or you're on with dyskinesias, because you can be on and have dyskinesias. And then are you off? Do you have dyskinesias as you're wearing off? So we can look at the timing of the medicine and what's happening between the doses. Okay, so that's on and off, and wearing off is a natural pharmacokinetic issue because levodopa is very quickly metabolized and eliminated, and you wear off because there's not enough dopamine stored in your brain. So there are medicines that we give to kind of prolong the on period. So COMT inhibitor, that's entacapone, it's included in Stalevo, gives you an extra hour of on time because it prevents the breakdown of levodopa by one of the enzymes being inhibited, So that little tricks that we can do to prolong the on time. Secondly, we can add agonists that aren't affected, they have a longer blood half-life. So Requip, Mirapex, Nupro, They kind of are used for people wearing off from levodopa because as the levodopa is wearing off, you have less dopamine. At least you have a substitute there, a synthetic dopamine. So you treat the gradual wearing off with adding COMT10 and you add an agonist. But then there's a sudden off. A sudden off is defined as going from on to off within a minute, within 30 seconds to a minute. And freezing is with a sudden immobility. You're walking, then you suddenly stop, usually in doorways if there's a lot of people. Those two cannot be improved by changing the medicine, unfortunately. Those are called pharmacodynamic problems. And there's something we don't understand why, even though the blood levels of dopamine are good, the agonist is good, you still freeze or you suddenly have an off period. Those are really difficult. We don't have an answer for that kind. So people that have sudden off and freezing are the ones that are falling because they're walking, boom. So there's no medicine that we know of for that yet. There are studies. I told this study, there was a drug called 3-adops that seemed to stop freezing in Japanese patients when we did it in Sweden and Colombia and New York. The results were not the same. The conclusion was this drug works only in Japanese people. But you know, the fact is there are no drugs. It doesn't really work in Japanese either. That was just a really poor design study. There are deep brain stimulating experiments going on, deep pacemakers in another region of brain that may prevent freezing, improve gait, and sudden off. And it's another system that becomes involved. As you all know, the illness doesn't begin with falls. If it begins with falls, it's probably not Parkinson's disease. It's atypical. It's usually lower body Parkinsonism. It's due to small vessel occlusions in the brain. It's, in other words, a vascular problem. So the disease begins on one side, eventually both sides, and when you start falling, usually 3 to 5 years after, it's because another system besides the dopamine system is involved. And that system involves deeper in the brainstem. It's called the pedunculopontine nucleus, and it's just being studied. Eventually, I'm optimistic there'll be a medication that'll prevent the sudden off, the freezing. There are physical things we do for freezing. Physical therapists do. And basically, if you have additional cues, like visual cues or rhythmic cues, you won't freeze. So if you tend to freeze going through a doorway, put some red masking tape 18 inches apart and step on each red line and you won't freeze. Having that additional sensory cueing. If you have a rhythm, you walk with the rhythm and tap, keep an internal count, like a march, 1, 1, and 2, you won't freeze. But a lot of people forget to do that. So in training, if you learn to develop additional sensory cues, you can deal with the freezing episodes. I would say there's another part of it. It seems as though the off period's happening about once a month, at roughly the same time of the month. Do lunar phases influence this? I love that question. It's magical. Well, the moon influences so much. The moon, the tides, the number of emergency room visits increase during the full moon. Why do you think they're called lunatic? You know, when they act like crazy, you know. But how it affects wearing off, I've never heard that. But people get migraines when they're menstruating. You know, there are effects, you know, the lunar effect really are just probably related anciently during evolution to women's cycling and menses, which is about every month. Now, I don't know if this is a person who's still menstruating. If the person is still menstruating, it may be because of what I wrote about the role of hormones, that maybe there is an issue during menstruation where people's Parkinson's symptoms get worse. So, but if this person is past menstruation and is having this lunar cycle, she just may be crazy. I'm just kidding. I don't know. I don't know how to answer it. But I needed a laugh. This is a very common problem, and so they ask whether it is common or uncommon. Is incontinence an unusual occurrence with Parkinson's? Is so, what's the best treatment? Well, remember I told you with the illness advancing, dopamine is not the only answer. We focus on dopamine because that was such an amazing breakthrough in 1960. But we know that other neurotransmitter systems, other parts of the brain, other parts of the body are involved in the disease process. So when the disease process involves the autonomic nervous system, which it does in Parkinson's disease, and in excessive amounts in Shy-Drager syndrome, there's constipation, bladder problems, drops in blood pressure, feeling hot and cold, perspiration. But the common elements are urinary problems where there's inability to completely empty the bladder, so one has to go frequently. Eventually, the control of the bladder is really difficult, so people can become incontinent of urine. And the way that we usually treat it, if the problem is occurring at night and people just have to get up every 2 hours to urinate, we give something to inhibit the bladder slightly, something like Ditropan or Vesicare, that inhibits the bladder so that so the bladder really fills up almost to its full amount before you have the need to urinate, so people can get at least 6 straight hours. That has a certain risk because in a man especially, if a man has prostatic hypertrophy, and then you're giving something to inhibit the bladder, they can end up with pretty serious urinary retention that needs catheterization and get bladder infection. So it's a very delicate issue. People that have a lot of urinary incontinence problems, urinary frequency, urgency, I refer to a urologist they do urodynamic studies. They really define, because there are 2 major issues with the bladder. One is that it's kind of spastic and all contracted and small. And the other is it's dilated and doesn't contract enough. So you have to determine which is the problem. They're both autonomic nervous system problems. And then to make it more difficult, men with the large prostate have an additional obstructive issue. And women who've had children sometimes have bladder issues because of all those kids kind of shifting the bladder around. The births, that's what I mean. So it's a difficult issue, and constipation is the same thing. If you look at the intestines, you'll see the same pathological process in the nervous system of the gut. The gut and bladder have an innervation, its own little nervous system that is controlled by the brain, the central autonomic nervous system controller. But those neurons develop Lewy bodies, which is the pathological hallmark of Parkinson's disease. So you'll see Lewy bodies in the intestines, and that correlates with decreased motion of the bowel, constipation, etc. So they're even using rectal biopsies early on to confirm Parkinson's disease in people that beforehand. I mean, it would be that we'd like to know who's going to be soon developing the signs and symptoms of Parkinson's disease. We need some kind of biomarker. It would be important if we had that so you could start treating it with an agent that's going to stop the progression. By the time you have the first symptoms, you've lost, maybe about 70% of your neurons. 70% of the dopamine and maybe 50% of your neurons, or even more. The numbers vary depending on what you read, but the idea is that when you have the first symptoms, this illness has been going on for about 10 years, like an iceberg metaphor. When what you see as the symptoms is just a little tip, but what's been going on in the brain is this huge thing, and it's been going on in the autonomic nervous system. You can see it in the heart rhythm as well, because the heart is controlled. The thing that accelerates the heart is the sympathetic neurons of the autonomic nervous system. And you can do a scan, a radionuclide scan, to look at the innervation of the heart, and that's an early indicator as well. So there's a lot of newer biomarkers that are being developed, allow us to see whether someone has Parkinson's disease before they have tremors, slowness, or rigidity. That'll be important if we're going to prevent this illness from expressing itself. What causes freezing? What can I do if I get stuck in place? Well, I kind of already talked about that. Well, if you get stuck in place, the old-fashioned thing would be have a bean bag, you throw the bean bag and step over it, or your spouse throw the bean bag. Some people have a laser light. Put on the laser light on their walker, laser light comes on, you step over it, and that breaks the freeze. I had an architect who designed his own cane, and he had a little lever. When he'd press the lever when he froze, a little rod would come down from the cane, and he would see the rod and step over the rod, and it would spring back up. So I saw him once almost trip on the rod. I'd rather have the laser light. the rod was a flexible, I mean, it was a very ingenious thing. He says, look, doctor. It was really cool. Look, he stopped and he almost tripped over the rod. Okay. Is double vision common in Parkinson's disease, or could I have another vision problem? Both are true. It is. Double vision occurs when each eye projects the vision, the image that it gets on the retina, to the occipital lobe, and they're merged because of the way the nervous system is. So you see one image. This binocular image results in a fused image in the back of the brain. So you see one thing instead of two. If the eyes are slightly divergent, in other words, instead of being yoked like a good pair of horses, one leans a little bit to the right, you're going to have double vision. That's what double vision is, as opposed to blurred vision, which may be a problem of the lens accommodation. And blurred vision, it isn't one image next to the other, but the double vision could be one slightly above, one slightly below. That is common in Parkinson's disease because of the asymmetry of the muscle rigidity of the eyes. You're aware that one side of your body is more rigid than the other. That's classical Parkinson's disease. But muscles that control the eye, there are 6 muscles for each eye, and they're skeletal muscles, and they get rigid. And if one side is a little more rigid, when you're off especially, you're going to have one eye a little bit less centered, and when you move the eyes especially, one moves better than the other, and then you have double vision. It becomes very hard to read because the eyes don't scan properly. So that's the common reason, and usually it gets better if you're on. So the medication usually results in normalization of the double vision, and the wearing off of the medication results in double vision. In that case, just adjusting the medicine can solve that problem. But if it doesn't solve the problem, you go to a neuro-ophthalmologist and they'll look to see if you have other reasons for double vision, and they'll give you prisms to adjust for it. Prisms would not be the thing to do if your double vision is due to the Parkinson's disease, because if he adjusts your prisms for when you're off, you'll see double when you're on. So you need to have a neuro-ophthalmologist that understands Parkinson's disease, and usually they're good. The neuro-ophthalmologists are probably, in my view, the brightest of all neurologists, because of the 12 cranial nerves, 6 of them, 2, 4, 6, 7 of them are related to vision. So someone who studies the role of the nervous system in vision really understands the nervous system quite well. So is depression a common symptom of Parkinson's disease? Yes. And that's an old story, really. First of all, depression and Parkinson's disease share a lot in common in terms of symptoms. For example, sense of tiredness, of fatigue. Well, people who are depressed feel tired and fatigued. People with Parkinson's disease feel tired and fatigued. People who are depressed have a sleep disturbance. People with Parkinson's disease have a sleep disturbance. There are derangements in serotonin and norepinephrine. In depression, there are the same kinds of derangements in Parkinson's disease. In fact, it's very unusual to find a Parkinson's disease patient who doesn't have some elements of clinical depression. And when we treat with antidepressants, a lot of this is better, and it reflects in a better control of the Parkinson's disease symptoms. Depression is the biggest amplifier of pain. So the people who complain of a lot of pain in Parkinson's disease, aside from having legitimate reasons like lower back pain, painful neuropathies, the depression amplifies. Depression turns up the volume on pain. And when you have more pain, the rigidity and slowness of Parkinson's disease is going to get worse. So it's a vicious cycle, so you have to treat the depression. But even more important is that about 60–70% of, this was a study done when I was at the University of Miami with Dr. Weiner, Dr. Schulman, and Dr. Levin. Dr. Levin's a neuropsychologist. And they looked at records of large numbers of people with Parkinson's disease that we had followed for many years. And they found that 60 or 70% of them had a diagnosis of depression before they had the diagnosis of Parkinson's disease. And almost as if depression is a precursor to Parkinson's disease. Now, I say almost. It's not the case because depression is is now perhaps overdiagnosed ever since the development of the Prozac and the, it's so available that it's very easy then to overprescribe these antidepressants. So, but there are, the antidepressants work by increasing levels of serotonin, norepinephrine, and dopamine. The old-fashioned antidepressants called tricyclics like amitriptyline and Elavil would increase all three. And automatically you're going to improve some of the Parkinsonism because you're slightly increasing dopamine levels, but not as much as you would if you gave levodopa. The newer ones focus on serotonin elevation, and that's the Zoloft, the Paxil, the Prozac type drugs, Celexa. So that's one of the drugs that's usually on the list of medicines I give to patients. I usually give it if they're having a sleep problem. I like to give an antidepressant at night that will make them sleepy, will elevate their moods after about a month, and really help the anti-Parkinson medicines work. If they're not having too much of a problem with sleep, I'll use antidepressants of the SSRI. SSRI stands for selective serotonin reuptake inhibitors, and that's the Prozac class of drugs, which is the most popular class of drugs used now of antidepressants. I'll tell you an interesting bit of history, because I like drug history. You know that MAO inhibitors, monoamine oxidase inhibitors, are what we use a lot in Parkinson's disease. Azilect is an MAO inhibitor. The new drug I talked about is an MAO inhibitor, the safinamide. Selegiline, which was created a big hubbub when it was first introduced, is an MAO inhibitor. And MAO is an enzyme, monoamine oxidase, that breaks down dopamine, serotonin, and norepinephrine. By inhibiting MAO, you increase levels of dopamine, serotonin, and norepinephrine. So you can imagine it's going to be an antidepressant. In fact, MAOs, inhibitors, were initially developed as antidepressants. But the only reason that they found out they were antidepressant in the 1950s, which is a lot of big advances in pharmacology, was there was a new anti-tuberculosis drug being given in sanitariums where the TB patients were kept. It was called isoniazid, and it was an MAO inhibitor. And it was very effective at treating tuberculosis. But the physicians would notice, people that have been on this for a month or 2 months in these sanitariums, they're dancing in the hall with joy. They're so gleeful and joyful, it's like hard to believe. They're away from their family. And they began to look at the antidepressant effects of MAO inhibitors. So some of the first MAO inhibitors began to be used as antidepressants, but they have too many other side effects. They were resurrected when levodopa first came, and there was an MAO inhibitor that was added with levodopa before we knew about carbidopa. But again, there's a lot of side effects with MAO inhibitors. They can cause, because they last a long time, and they can cause like serotonin syndrome, a whole bunch of stuff that is adverse effects. So we don't use MAO inhibitors as antidepressants anymore, though they have an antidepressant effect. I often wondered if that was not the reason that selegiline resulted. Remember, we were using selegiline and Azilect to delay the need for levodopa, to slow progression. I always am suspicious that there was a mild antidepressant effect so that people didn't need the levodopa. It seemed to delay the Parkinson's disease, because it's never been explained, and perhaps it is a mild antidepressant effect. So, how is Parkinson's dementia different from Alzheimer's disease? Well, that's a very difficult question, but I can simplify it. There's a Alzheimer's disease that is confirmed pathologically. They have amyloid, the abnormal protein deposits between cells. They have an abnormal twisted protein called tau, and they develop a dementia that begins with short-term memory problems. It involves the hippocampus and temporal lobes and progresses until they get very disoriented, they stop recognizing family. A certain percentage of those people, like 10% of them, will develop signs of Parkinsonism, slowness of rigidity, loss of balance, tremors. And if you look at those brains, you'll see Lewy bodies, plus the pathology of Parkinson's disease, plus the pathology of Alzheimer's. So some people, because they're both very common diseases, the two most common diseases involving loss of neurons in the brain is Alzheimer's and Parkinson's disease. So it's not unusual to have both. So if you see a Parkinson patient who has a dementia, the first thing I'll do is have a neuropsych evaluation because there are different patterns of cognitive loss, of the domains of cognition. I'm not going to get into them other than the memory is not so bad in Parkinson's dementia. It's more spatial perceptions and executive function, planning ahead, carrying things out, multitasking. All of those are characteristic of the dementia of Parkinson's disease. And when you look at the people with Parkinson's disease dementia, they are really different than the dementia of Alzheimer's disease. They eventually do develop some memory problems. They don't develop such severe dementia as in Alzheimer's disease. And if the brains are looked at, you'll see that they have only Lewy bodies, but no amyloid plaques or no neurofibrillary tangles. So that's the main difference. One could have dementia with Parkinson's disease. And let me go. There's a third category. I don't know how I could skip it. So you have Parkinson's disease with a very typical kind of dementia that happens. Spatial perceptions may change, executive function, versus Alzheimer's with some elements of Parkinson's disease. But there's a very rapidly progressive form of Parkinson's disease that involves those Lewy bodies involving the cortex, the hippocampus cortex, and that's called dementia with Lewy bodies. And that presents differently. It can resemble, in many ways, Alzheimer's disease. Pretty severe memory loss, disorientation, etc., getting lost in your own house. But usually it's heralded by hallucinations and a severe dementia followed soon after by signs of Parkinson's disease, as opposed to the Alzheimer's patients, Alzheimer's for a long time, and towards the end may have some mild Parkinsonism. So dementia with Lewy bodies is not that unusual. It falls in the category of Parkinson's disease syndromes because the pathology involves a certain proteinaceous material that accumulates in neurons called Lewy bodies. So it's a complicated thing. How do you treat it? This is something that is, in the Alzheimer's dementia, we use agents like Aricept that increase acetylcholine levels, and it helps a little bit with short-term memory. We do that in some cases of Parkinson's disease. And I know that Dr. Chase and Dr. Clarence Smith have a new variation of these kinds of drugs used for Alzheimer's that may be applied to Parkinson's disease that may help cognitive function there. These new drugs that we may be testing here have increased penetrance into brain, unlike Aricept for Alzheimer's disease. There's another drug that we use for all of the conditions called Namenda. And that has some mild improvement in cognitive function and some mild neuroprotective effects. I think I'm down to the last question. There's a couple others, but I'll just pick one of them. I was told recently there's a strong link between diabetes, Parkinson's disease, or Parkinsonism and Alzheimer's. True or false? False. It's not a strong link. People with diabetes end up with a microvascular disease. What suffers the most in your body, which if you have diabetes, poorly controlled diabetes especially, is the small capillaries that provide the final blood to all your organs, the kidneys, the retina, the heart, the brain. That's why you develop disorders of all those organs if you have diabetes. You get peripheral neuropathy, heart disease, stroke. But the microvascular disease, if it's involving the white matter under the cortex, if it's significant enough because of the diabetes, you can develop what's called lower body Parkinsonism. Usually develops later in life, usually diabetics that have even well-controlled diabetes, and they have a problem with gait, where the gait is like this, but the arms are loose, they hardly have involvement here. I see plenty of them here because they're misdiagnosed as Parkinson's disease. I get a history of how it began. It didn't begin on one side and then the other side and then legs. It began with gait. When I watch them walk, it's like this. They don't respond well to Cinemat. They tend to have diabetes, but they may not. So that's a link between the diabetes or microvascular disease and lower body Parkinsonism. But classical Parkinson's disease has normal blood vessels, doesn't have microvascular disease. Unless you're really, when you're older, everyone has these small microvascular changes. I'm talking about when you're in your 80s, 90s, you'll see that. Usually Parkinson's disease is diagnosed at the age of 60, Lower body Parkinsonism, usually late 70s. In Alzheimer's disease, there's a closer relationship between microvascular disease and Alzheimer's plaque deposition. It's almost as if kind of leaky small blood vessels allow for the accumulation of amyloid. And there is an association between microvascular disease and dementia. When it's really severe, it's called arteriosclerosis, and that was dementia that we used to use. That term, arteriosclerotic dementia, was an old-fashioned term, but we think a lot of Alzheimer's is microvascular in origin. And what is the worst microvascular insult? Diabetes. So that's the relationship. It isn't a strong link, but it doesn't surprise me when I see diabetics having either cognitive changes or movement disorders. In diabetics, usually have more of a gait disorder because they have neuropathy plus lower body Parkinsonism. So their problem is mostly gait, not problems with the use of the hands. I think that's it. It gives me a chance to start up my computer. Thank you.